Right. Okay. Greetings to everyone. Thank you for your attendance. My name is Dusane Dembe. I'll be the host of the session. So today's session is um, approach to abdominal pain with the suspicion of acute abdomen. Today, our host is Professor Martin Brand, who is a hepatobiliary surgeon. Prof has introduced himself a number of times, and I won't be doing justice today if I ask him to introduce himself. Um, thank you, Prof. Welcome to our session, and it's always a pleasure to have you around here.
Thanks for the invitation.
Yes. So, Prof, today's topic is approach to abdominal pain. As you already explained previously, that if we say approach to abdominal pain with the suspicion of acute abdomen, then it means a patient will present with abdominal pain, and then within the abdominal pain, one has to be able to notice that, okay, I'm dealing not just with abdominal pain here, but with an acute abdomen. Having said that, in your definition in the voice notes, Prof, you defined acute abdomen as a sudden, severe abdominal pain that has a duration of less than 24 hours, which is life-threatening or serious, that needs urgent medical attention. Now, Prof, okay, and then you later on said when you're dealing with abdominal pain, it needs um, urgent attention. So now in your assessment, you said just like a trauma patient, you start with your airway, breathing, circulation, and then you do your abdominal examination, and then you also do chest examination. And then you also said in an attempt to try and identify where could be the problem, we must break it into quadrant, which is much an easier um, way. Draw it into quadrant. You've got the right upper quadrant, left upper quadrant, and some others they even have 9 quadrants. So to try and depict what I'm talking about, I have a picture which is taken from Google to depict what I'm talking about, the quadrants. The quadrants, okay, so, okay, yes. So I was trying to share my screen here so that you can see. Right. Yeah, the quadrants. Can you all the 4 quadrants. This is what we're talking about, Prof, right?
Correct, yeah. Happy with that.
Yes, and then there's also this is a picture from Google. There's another one that I found that has they further break it down to 9 quadrants. Yeah, where one can then decide which is more. I'm not sure if more specific. What do you think of this one, Prof? We prefer the other one.
I mean, this image is correct. I just find that it's a bit confusing. And I think in clinical practice, when you look at a patient's abdomen, it's a lot more difficult to divide the abdomen into these 9 areas because there might be a little bit of an overlap. So that's why I must say I personally very much prefer the 4 quadrants. It makes it very straightforward, and also very easy to remember. And it also takes away that overlap issue where you've got those 9 quadrants where if you have, for example, in this, you'd have right lower quadrant pain, maybe it's an appendicitis. The quadrants that you had, well, they're not really quadrants, they're nines. It's not necessarily that easy to see that because then you could have pain in segments 4, 5, 7, and even in 8. So it becomes a bit more difficult. So I find this is just too complicated for my liking, but it's not incorrect.
Okay, all right. So, Prof, there are some terminal. Okay, so and then yeah, you said assessment. based on the quadrant, one can then decide, one can get a clue based on the history and physical examination, one can get a clue of where exactly the direction of the diagnosis or the differential diagnosis. Now, there are some terminologies, Prof, that I want us to, there are some terminologies that I want us to zoom on because in the clinical practice, they are loosely used. They are loosely used, and when you try and find out exactly what do they mean, sometimes there's that difficulty. When we say a patient has a surgical abdomen, if you have any questions, you can raise your hand or send it in the chat box. When you say someone has a acute, sorry, when you say someone has uh, profile,
Yeah, I'm here. I'm
yes,
listening.
yes. When you say someone has um, uh, peritonism, what exactly do we mean, Prof?
So if you think about it, peritonism is inflammation of the peritoneum, which is the lining of the abdominal cavity. And to get inflammation of the lining, you need some sort of a pathology that causes inflammation. So if you go look again at, I mean, I come back always to the appendix because it's the most common surgical emergency, abdominal surgical emergency. So if you have an inflamed appendix, that's going to present because the appendix is in contact with the peritoneum and the right iliac fossa. So, and the peritoneum has nerve fibers that run, and the innervation of the peritoneum is very localized, and it's related to the vertebra. So, if you initially have a bit of peritonitis, it's not a complicated appendix. It hasn't perforated. There's not pus that's now spread throughout the abdomen. You get a very specific pain in the right iliac fossa, and it's purely because the appendix is in contact with that peritoneum. So if the appendix now, for example, has a fecalith, it becomes blocked, it becomes inflamed. It's now lying on the peritoneum, and it spreads the inflammation there. And that's why you have the localized peritonitis. A diffuse peritonitis, though, is if you have peritonitis throughout the whole abdomen, which means all of the peritoneum in the abdominal cavity is inflamed. And you get that is if you have, for example, an appendix that is perforated, it's now created pus, and that pus then spreads throughout the abdomen. So in other words, it's in contact with the peritoneum throughout the abdomen. Then you get a generalized peritonitis. So no matter where you examine that patient, they're going to have rebound and guarding, even if you go into the left upper quadrant. But in that same patient, if you go into the right lower quadrant, they also rebound and guarding. So then your mind has to change a little bit and say, well, what intra-abdominal conditions can give you a generalized peritonitis? And it's usually the septic ones. So for example, a perforated peptic ulcer initially will be localized inflammation in the left upper quadrant, but if it starts generating pus, etc., and that pus then starts spreading throughout the abdomen, the patient can present with a diffuse peritonitis. Um, so that's why a diffuse peritonitis, you need to think a little bit more holistically and say, well, what likelihoods are there of having a diffuse peritonitis? Is it a perforated viscous? Is it a perforated peptic ulcer, perforated bowel injury? Is it a bad appendix? Is it a bad diverticulitis? Because even with diverticular disease, yes, initially it creates a peridiverticular abscess, but that abscess can rupture. And once that abscess ruptures, that pus can then spread throughout the peritoneal cavity. And then they can also present with a diffuse peritonitis.
Right. Okay. So, just for clarity, Prof, peritonitis and peritonism, what is the difference?
They're the same thing. Peritonitis is the inflammation of the peritoneum. Peritonism is a clinical sign of that inflammation. So it's exactly the same thing. It's just you would describe it and say, my patient has got peritonism, which is the clinical interpretation of peritonitis.
Okay, number one. And then now, uh, in clinical practice, how do I prove that the patient has peritonitis or peritonism?
So peritonitis is what we call rebound and guarding. So in other words, when you palpate the patient's abdomen, generally, if they have a bit of pain, You can still palpate the abdomen. They're not going to flinch. The abdominal wall is not going to have what's called rebound. If you go back to examine them, the patient's not now going to try and protect themselves. The abdominal wall moves involuntarily, which is called guarding. So if a patient has rebound or guarding, that is a sign of peritonitis.
Right. Okay, so what's the difference then, Prof, with rebound tenderness and muscle guarding? Because sometimes that terminology,
Well, it's the same thing. So rebound means that if you palpate a little bit deeply, so maybe you push the abdominal wall in by a few centimeters, and then you remove your fingers very quickly, that the abdominal wall goes back into the position it was before you palpate it. That creates pain for the patient. And the patient either complains and says, "Wow, that was incredibly sore. Please don't do it again." Or you can see that they have a grimace on their face, etc. Whereas guarding is now when you come back and try to do it in another quadrant, for example, so with a diffuse peritonitis, and you go there, the patient now knows if this doctor does this to me or this person investigating, examining me does this again, it's going to be very painful. So they sort of flinch, and that's called guarding. And you even have what's called involuntary guarding, where it's a subconscious things where you now come towards them and you want to examine them, and you can already see that that abdomen is tensing up. The patient might even take their hand and try to stop you from putting your hand onto the abdomen. That's also guarding. So it's just prevention of that deeper palpation is what's called guarding. And the rebound is that reflex as soon as you let go with your fingers that it jumps out at you and it causes them pain.
right. So now in someone who's maybe there's a hospital that you used to like in Pumalanga, Prof, I forgot the name. You like
There's a few out there, yeah.
Yes. So if the patient is deep down there in Pumalanga and
Yeah.
they are having a patient with acute abdomen, what are the
Mm.
general practice other than the one you've mentioned in the voice note that you have to do your ABC and then you do your abdominal examination, your chest examination. What are other basics, considering the fact that this patient is not gonna go to theater immediately, there's still gonna be a transport, they still need to be assessed in the
Mm.
other hospital.
Yeah, so it comes down to what you think is the cause of that acute abdomen. So wherever you are, you have to still do your A, B, C, Ds. So you have to assess the airway they're breathing. Do they require supplemental oxygen? If they do, is it via nasal cannula? Is it via mask? Is it via intubation? If their blood pressure is low, you give them fluids. If it doesn't come up, then do you need to give them some adrenaline, some noradrenaline? And then you need to say, well, I think this is an infective cause because maybe from the history they had periumbilical pain and went to the right iliac fossa, and now they've got a diffuse peritonitis. So my number one diagnosis is acute appendicitis. Or did they have maybe epigastric pain? They have a history of previous peptic ulcers. So maybe they had a peptic ulcer. So you need to give them antibiotics. So what I'm saying is you need to decide, do you think the most likely reason for this patient's acute abdomen is something that's septic, or is it something else, like a ruptured aortic aneurysm? If you think it's something septic, you must put them on antibiotics as soon as possible, and you should put them on a broad spectrum antibiotic. But having said that, though, if the patient has come from home, which in that scenario that you've described most likely is the case, then you can give them augmentin or colmoxiclavulanic acid. That's more than enough broad spectrum. But if it's a patient who's been lying in hospital, maybe they've had some other problems, they haven't been getting much better there, or they've been kept a bit longer, and now all of a sudden they've developed something new, which is this acute abdomen, then you have to assume that the bacteria that are causing that infective complication or making it worse are hospital-acquired bacteria, and you need to use a lot stronger antibiotic because, as we know, hospital-acquired bacteria and infections are usually resistant to the more common antibiotics. So in that kind of situation, you use something like tazocin to give them antibiotics that way. And then you need to expedite the referral. So you need to phone whoever the referral center is that you have to phone and say, look, you've got a patient with an acute abdomen, these vital signs. This is what you think is the most likely diagnosis based on what the reason is. If you've had an opportunity to do blood results, is to present, for example, the arterial blood gas or if you've been lucky enough to get a full blood count and a white cell and a UNE and a CRP, you can present that. But often you won't have that at that point in time because those are not necessarily always quickly available. And then you say, right, I think my patient is critically ill. They've got septicemic shock. I've started antibiotics, but we cannot operate here. We need to refer the patient to you as a matter of urgency. And you go from there that way. If you think it's a non-infective thing, so for example, maybe it's a ruptured abdominal aortic aneurysm, then you know that resuscitation is a major problem for you because you need to keep that blood pressure up so that the patient doesn't pass away because of no blood pressure. So that's where you would then put in two wide bore. You'd give them fluids, you'd give them blood, and then you need to phone the hospital that you're going to refer them to and say, this is why you think the patient has a ruptured AAA, and this is why the patient needs to come to you as soon as quick as possible. And then you organize a referral. And often the doctors that you refer to will also give you advice on what you must do until the ambulance comes there and what you must have in place for when the ambulance arrives. Because you must also remember that in these rural areas, these ambulances that come are usually not very high-tech ambulances. They're basic life support ambulances. The person who's driving the ambulance very often doesn't have a basic life support certificate or anything. They're just the driver. And you've got an ambulance attendant who's really not a very qualified individual either. They often just have a basic life support, etc. So you need to be able to put that patient onto that ambulance and know that the patient's going to survive however long it is to get them to that center. And in these cases, and I remember I worked for a while in the Republic of Ireland, and even in the Republic of Ireland, we have rural areas where there's very little to do. My superiors used to say, right, this patient is sick. You're going in that ambulance with the patient, and then we will see how we get you back to our hospital. But for now, you yourself must accompany that patient to the hospital because the person who's in the ambulance cannot administer medication, cannot really assess much because they just don't have that experience. So I would strongly say if you really have a critically ill patient, the best thing you can do for that patient is actually accompany the patient in the ambulance to where they're going to give them the best chance of survival.
Right. So, Prof, there are school of thoughts, the one that you mentioned in the voice note, but I'm gonna start with the antibiotic one. There was a school of thought that said if a patient is, for instance, the most common one, appendicitis, they say if the patient is having appendicitis, don't give antibiotics because when they do investigations on their side, the left shift and the CRP rate are not going to be as elevated as they're going to be if you didn't give an antibiotic. What is the latest school of thought in the current era that now that I'm in the primary healthcare and I'm seeing a patient, I'm convinced that this patient is having appendicitis. Do I give antibiotic or
Definitely. So I think that that controversy is no longer valid. So in that was even changing in the back in the days where I was training as a surgeon. So the thinking in the past and the reason where this came from is that, for example, with acute appendicitis, if the patient presents to you very early, the clinical signs might not be as obvious as if they present a little bit later with the peritonism, etc. So often you might have a child or a teenager. You can also have it in adults, but they present and they say, yeah, I just don't feel like eating. I feel nauseous, but I haven't vomited. I just don't feel great. I had this bit of pain around my belly button. And yeah, so I'm not good. And when you examine them, you see that they're a little bit tender, maybe in the right iliac fossa with deep palpation, but there's no rebound, there's no guarding. So now, does that patient have acute appendicitis or not? And in the old days, they used to say, you know what, you need to let that mature. So let it develop. Don't give them antibiotics, admit them to the ward, and then you do your serial clinical examinations. And if it disappears, it disappears. And then maybe the patient had mesenteric lymphadenitis, is not treated with antibiotics, or it gets worse and worse, and now all of a sudden they have that rebound and guarding in the right iliac fossa, especially over McBurney's point, and now you have your diagnosis, and then you give antibiotics. So sooner in the old days, as soon as you had your clinical diagnosis, of an acute appendicitis, you used to give antibiotics. However, that's changed a lot. And the reason why it's changed is we really don't want to delay the patient because appendicitis can become very complicated. Patients can become very ill from it, and they might end up staying in the hospital a lot longer than they should. They might need more operations than just the one appendicectomy. So once you have your suspicion that there's an acute appendicitis, you should give the antibiotics, especially if you're in the rural areas where it's going to take you time if the patient all of a sudden does develop an acute abdomen. Now all of a sudden you have to wait the 6 hours or the 8 hours for the ambulance to arrive to take them to where they're going to have their appendix taken out. What we also have nowadays is that one of the best ways of diagnosing acute appendicitis, or accurate ways of diagnosing it, is with an ultrasound, which is available in most hospitals. So people who can do an ultrasound, it's a very sensitive way of diagnosing acute appendicitis, and it doesn't delay the patient. If you give the patient antibiotics, and so for example, maybe it's a patient that comes in at night. You don't have ultrasound available at night. Give the patient antibiotics. Let them have the ultrasound the following morning. Those few doses of antibiotics are not going to change the picture of the appendix on the ultrasound. Or if you're fortunate enough to have a CT scan, it's definitely not going to change the picture on a CT scan, which will then make the diagnosis for you. And then what you've done for the patient is you've probably prevented them from developing severe complications of acute appendicitis. So I think nowadays, if you think you've got an acute appendicitis, give them the antibiotic, complete your investigations. If the investigations come back and say, you know what, it's not appendicitis, it's maybe an ectopic pregnancy, it's maybe whatever, then you say, okay, I'll stop my antibiotics. Then you don't need to carry on. It's the same with analgesia. In the old days, people used to say, oh, I'm not quite sure about this abdomen, so I'm not going to give them painkillers because if I give them painkillers, it might mask the signs of peritonitis. So it might delay my diagnosis of the peritonitis. And as I mentioned in my voice note, there have been many studies now that show very clearly that giving them analgesia and giving them appropriate analgesia. So if your patient really is in a lot of pain, there's no reason why you should not give them an opiate. Give them morphine. Give it to them IV if they really need it like that, because you actually diagnose the underlying pathology earlier and the patients tend to do better. So yeah, so those are two big changes. And again, if you read very old books, and when I say very old books, maybe something that's been published 15 years ago or so, so it's not that old, but it was still there in those times. But nowadays, give your patient painkillers if they need it, give it to them, don't withhold it. That is just it's just unethical and inhumane. And if you think you've got something septic going on in that abdomen, give them the antibiotic. You can always stop the antibiotic instead of starting the antibiotic late because you weren't convinced of your diagnosis.
Right. So, Prof, thank you for for that clarity. The issue of surgical and non-surgical management of acute abdomen, how do you decide in terms of primary healthcare, or your advice would be just send if the patient is coming with the acute abdomen, just refer,
Yeah,
because
I think
lately,
you have to. The the things that we do to decide whether or not, so even for example, acute appendicitis, there are cases that we can manage medically that don't need an appendicectomy. But we need special investigations for that. And in the primary healthcare section, you don't have it. So I think in the primary healthcare setting, the job is my patient acutely unwell? Are they stable or unstable? Do they have a surgical problem or not? And then to refer them. You're not going to be able to decide whether or not that diverticular abscess that the patient has, whether or not that can be managed with just antibiotics, or it needs a percutaneous drain, or maybe it even requires a laparotomy. Or you also cannot decide in the primary healthcare sector whether or not that acute appendicitis can be managed with antibiotics, or does it need antibiotics and surgery? You're not able to make that differentiation. So the job in the primary healthcare sector is to say, right, this is a patient who's got an acute abdomen. I'm worried that it's a surgical abdomen, so I'm referring it to the surgery department. Or I'm worried the patient is in a DKA. I've diagnosed the DKA, but the patient also has an acute abdomen. So I'm more worried that it's a DKA that's causing the abdomen. So I'm going to refer it to the medical department. Or if you're worried about angina, for example, but the patient has an acute abdomen, refer it. It's not for you to decide whether or not you can manage it at that primary healthcare hospital or where you are.
All right. Thank you, Prof. Gonna take questions. If you have any questions, you can type in the message chat, or you can raise your hand, or alternatively, you can unmute yourself. I like to believe that the most acute abdomen patients are the appendicitis. Lately, in the tertiary hospital, how's it been looking like, Prof?
It's exactly the same for us. We probably do between 10 and 15 appendectomies a week.
Okay, then I guess one of the sessions will have to be approach to abdominal pain with the suspicion of appendicitis.
Yeah. No, appendicitis is very common.
All right. I see that there are no questions. So, in the absence of questions, you can still type your question or unmute yourself or type in the group. I would like to take this opportunity, Prof, and thank you for your time. You've got an open door policy. You always allow us to invite you.